Okay, I think we'll get started. Before we do so, I'd like to recognize that we're on the traditional, ancestral, and unceded territory of the Hunkaminam-speaking Musqueam people. I'm absolutely delighted to introduce today's speaker, Professor Kerry Courneya, who is giving this talk as part of the Don McKenzie Lectureship, named after Don, who we're delighted is able to join us today, in recognition of Don's exceptional contributions to sports medicine in Canada, and in particular his research and applied work with breast cancer survivors. It's very fitting that Professor Courneya is giving the Don McKenzie Lecture. His research program focuses on the role of exercise after cancer diagnosis. His contributions to exercise oncology have been widely recognized by being appointed as an officer of the Order of Canada, another notable accomplishment that he shares in common with Don. Kerry's a Tier 1 Canada Research Chair at the University of Alberta. He has over 600 publications, an H-index of 150, yikes, and has trained a number of exceptional trainees and graduate students over the years. We're very lucky to have Kerry speak with us today. But before this happens, I know that Don wanted to say a few words. So Don, I'll hand over to you.
Thanks, Mark. So I know Kerry as just a good guy, and that's, he's a terrific scientist. His awards and achievements reflect that. But not only being a terrific guy, he's just a super mentor to a lot of students and professional people. And so having my name connected with him is a real honor. Seriously, a real big honor for me. Very briefly, I was talking to some oncologists, breast cancer oncologists, earlier this year. And we were discussing immunotherapy and how this could be a big game changer for the management of patients with cancer. And it's got a ways to go yet, but the future is looking very bright. So we were talking about that. And then what we did talk about is what's happened to the breast cancer patients over the last 20 or 30 years. And the oncologists had to agree that the biggest change that had happened to the patients was due to the implementation of physical activity. So if you do a little bit of exercise, you get a 35 or 40% reduction in recurrence rate. That's pretty huge. So the person who's responsible for a great deal of that happens to be sitting over here, Kerry Courneya. He's been a quarterback of a lot of the exercise studies that have occurred. He presents them globally. They're well published. Very, very important things. What I like about today is that now we have the word breast cancer, exercise, and cure all on the same page. So that's a new way of looking at things. So we used to think exercise is helping in the management of, contributing to, helping with side effects, etc. And you start to put the word cure up on the bulletin board, then you really get a lot of attention from the oncologists and other people. So I'll pass this on to Kerry, but it's been a real honor to have him here. I'm happy and looking forward to his speech.
Good afternoon, everyone. It's a pleasure to be here. Mark, thank you so much for the invitation to give this Don McKenzie Lectureship. And Don, thank you to you for making this all possible. And you made it possible, I think, in a couple different ways. One, thank you for having such a stellar career that the School of Kinesiology felt compelled to develop a lectureship in your name. I think that's pretty impressive and fairly rare in departments of kinesiology across the country. But secondly, I think you made today possible by influencing my career in exercise oncology. Don was one of the early researchers who influenced how I think about the field of exercise oncology. So I'll start just briefly with a couple of the collaborations that Don and I did together that I think are very important, have influenced my thinking. So the first collaboration, Don, you'll remember, is the START trial, and that was conducted 2003 to 2005. And this was a multi-center trial, including Don's team here in Vancouver, Roanne Siegel's team in Ottawa, and myself in Edmonton. And we recruited 242 breast cancer patients going on to chemotherapy. So it was the largest study at the time and the first to really tie exercise to the chemotherapy period. And Don played a critical role in this study. He was responsible for developing the exercise testing protocols and coming up with the exercise prescriptions and progressions that we tested in this study. And we compared aerobic exercise to resistance or strength exercise in usual care. We had lots of important findings. This study is most noted for showing the impact of strength training or weight training on chemotherapy completion. So patients who did weight training during chemotherapy completed more of their chemotherapy than those who didn't exercise. It was the first study to show this, and it is now a very hot topic in the field of exercise oncology, whether or not exercise can influence chemotherapy completion rate. This study, though, is far less heralded for, I think, another very important finding. And we did measure lymphedema in this study. We did arm volume measures, arm circumference measures, and we showed that a very vigorous strength training program, an aerobic exercise training program, did not cause or exacerbate lymphedema. And this was following up on Don's early work showing that patients could do these vigorous intensity exercise programs. So Don, I kind of view the START trial as the large confirmatory trial for many of your earlier studies showing this. And here we were able to confirm that this is not an adverse effect of exercise. And lastly, by doing this multi-center trial with large number of patients, we were able, I think, to usher in the era of precision medicine in exercise oncology. So with this large sample size, we were able to do some subgroup analysis showing which patients benefited most from aerobic exercise during chemo, which patients benefited most from strength training, and begin to look at this type of precision medicine approach. So after a 7 or 8 year commitment, I asked Don if he wanted to make another 7 or 8 year commitment. So we followed up the START trial with another trial we call the CARE trial, and this was conducted between 2008 to 2011. And here we looked at the dose of exercise, higher dose exercise prescriptions, including more aerobic exercise or adding strength training to a standard aerobic exercise program. And this was the first trial to sort of look at a dose response exercise during chemo. And in this trial, we randomized over 300 breast cancer patients initiating chemotherapy. Very large sample in the field of exercise oncology. All sorts of findings were published, but once again, we were able to do this precision medicine approach and find out which patients benefited from the higher dose exercise programs and which patients didn't. In other words, standard aerobic exercise was all they needed, and higher doses were not helpful. So those are a couple of the studies that Don really played a critical role in early in my career and influenced my thinking. And I'll move on now to my topic for today, which is more shifting towards this idea of exercise as a cancer treatment. And so exercise is well established as a supportive care intervention. And so by supportive care intervention, as Don mentioned, we think about things like quality of life, symptom management, improved fitness, and so on. So it's very well established that it has these types of benefits. And we've seen these benefits before, during, and after different treatments, and across all disease stages, and across many different cancer types. Not all cancer types, but many of them have been studied. And these supportive care benefits have been sufficient for many organizations. Many countries around the world have now issued exercise guidelines for cancer survivors. Of course, we've had exercise guidelines for cardiac patients for 60, 70 years. And the first ones that came out in exercise oncology were 2009, 2010. So it's a very recent phenomenon for any of these societies to recommend exercise for cancer patients. And Kristen Campbell here at UBC led the American College of Sports Medicine guidelines and the updated version in 2019. But I think probably a really important milestone in our field was the guidelines that came from the American Society for Clinical Oncology. So these are the oncologists, the cancer doctors who treat cancer patients. They're not wedded to exercise. They simply look at what is good for my patients or not. And so in 2022, they reviewed this field of exercise oncology and said the benefits are compelling enough that we should be recommending exercise, as you can see here, during treatments to help mitigate side effects of cancer treatment. This has included things like reducing fatigue, improving cardiorespiratory fitness, improving quality of life, reducing anxiety, and importantly, a low risk of adverse events, including lymphedema, based on Don's earlier research. But what you'll note here is the recommendation is for exercise to manage the side effects of treatments. There's no recommendation that it's going to act as a cancer treatment. In fact, they explicitly say in these guidelines that the evidence for any clinical benefit to patients in terms of the cancer outcomes is insufficient. So oncologists right now will recommend exercise for approved side effects, but not as a cancer treatment. So to me, this is one of the next kind of key areas for exercise oncology, to look at this particular issue of whether or not exercise may act as a cancer treatment and not just as a supportive care intervention. So exercise has been proposed as a possible cancer treatment. And this research has been around for a number of years, a couple of decades, but it's all been kind of preclinical rodent models where they've kind of shown some effects of exercise on tumor growth. And then these observational studies that Don talked about, higher levels of physical activity associated with a lower risk of cancer death and recurrence, but not really clinical trials. We haven't done the clinical studies to definitively show that exercise improves these cancer treatment outcomes. And the key point that's made, particularly in these animal studies, is that the exercise treatment studies need to reflect clinical practice. We really have to mimic what's going on in clinical practice, just like they would for a new drug or a new radiation therapy treatment. And so I started thinking about this area of how we would reflect clinical practice in cancer and begin to test exercise as a cancer treatment, and realize there's an infinite number of clinical oncology settings. Cancer is a very, very complex disease with all sorts of subtypes, and the treatment protocols are very diverse. And so there's a lot of different scenarios we could look at. So it might be helpful to propose a framework. A conceptual framework might help us structure and organize these clinical oncology settings and identify what are the critical aspects of clinical oncology settings from an exercise perspective, and where might exercise be most likely to fit in and serve as a cancer treatment. So I've called it the EXACT framework, exercise as cancer treatment. For those of you interested in the gory details of this framework, you can take a look at this particular paper done with Chris Booth, who's a medical oncologist out of Queens. And then we also developed a second paper that expands on the framework and looks at observational studies on how they might be designed to look at exercise as a cancer treatment. And we talk about the framework in a bit more detail. But to give you an overview of it, the framework proposes there's two key variables that influence these exercise interventions. One is the tumor or disease status of the patient, and the other is the treatment status of the patient. So by tumor or disease status for the patient, there's three categories. One is that the primary tumor is present. So we're doing an exercise intervention while the patient still has the primary tumor. Or we're doing the exercise intervention after the primary tumor has been removed, which is very common. So for many cancer patient groups, they go straight into surgery fairly quickly. And by the time exercise intervention could be performed, the primary tumor is gone. So in that scenario, we're looking at treating any kind of micro-metastases that might have been shed from the primary tumor. And then, of course, we have this metastatic disease setting, widespread cancer, and what's the role of exercise when some patient already has widespread metastatic disease. This is an important distinction because these reflect what's called different steps in the metastatic cascade. So how cancer goes from a very small primary tumor into widespread disease. It goes through various steps that I'll show you in a moment. And also the genetic and epigenetic differences among these types. What the cells that are in the primary tumor are different than those that are shed and disseminated elsewhere. So metastatic tumors don't necessarily have the same genetic mutations as the primary tumor. So just because exercise helps with the primary tumor doesn't necessarily it would help with metastatic disease and vice versa. So we have to take this stage into account. So if you think about it, we start off with a primary tumor, a small cancer that is going to be discovered at some point. And that primary tumor can grow and invade local tissues. And then it gets into the circulatory system. And that's how it spreads. It survives in the circulation. It arrests at a distant organ site. And then it leaves the circulatory system and goes into these distant organs. And then you end up with disseminated tumor cells. So when we're talking about exercise in patients with a primary tumor, the goal then is to get rid of that primary tumor, to shrink it or to make it less likely to shed cancer cells that are going to be disseminated. In the second scenario, the primary tumor is removed. So the question there is, once the primary tumor has been removed, is there any small number of tumor cells that have been disseminated? So did that primary tumor shed some cells before it was surgically removed, and now we have disseminated tumor cells? And under that scenario, the goal of exercise is to prevent those small number of disseminated tumor cells of growing in these distant sites, becoming metastatic colonization, and then ultimately macroscopic metastasis. So these tumors that we can detect. So this typically the term we use is recurrence. Do these disseminated tumor cells show up down the road that the cancer has come back? So we're really looking at exercise as preventing a recurrence. Under the metastatic setting, we've already got macroscopic widespread disease, but that disease continues to grow, it continues to spread, it then infiltrates vital organs and then ultimately causes death. So what we're looking at here for the role of exercise is, can it prevent this metastatic disease from continuing to progress and ultimately leading to death? This scenario is really thinking about cancer as a chronic disease, right? Most of these patients are not going to be cured, and so you're really looking at managing a chronic disease, and can exercise slow the growth and spread of that disease. The second key thing we need to look at is treatment status. So what's the treatment status of the patients? And these patients can be treatment naive, meaning the cancer cells have not been treated yet. They can be actively treated, meaning when we're doing the exercise intervention, the patients are already being treated for that particular cancer. And they can also be previously treated, meaning we're intervening after those cancer cells have been treated. In some cases, heavily treated. This turns out to be critically important because cancer treatments alter the genetics and location of these remaining cancer cells. So a cancer cell that's not been treated is very different than one that's been treated. It can develop newly acquired resistance mutations, so it becomes genetically different. So just because exercise might influence a cancer cell that's not been treated, after it's treated, the effects of exercise might not be positive, or it might be positive. In other words, however that biology and genetics of the tumor cell changes might make it more or less sensitive to an exercise intervention. So treatment sequence can alter these exercise effects. And this turns out to be a critical variable in clinical oncology. We're getting a growing number of cancer treatments. We put a lot of treatments for these patients. And how you sequence those treatments. Is it chemotherapy first, followed by surgery, and then radiation therapy? Or is it surgery first, followed by chemo, radiation therapy? And then these newer targeted or immunotherapies, are they later on in the treatment sequence, or are they beforehand? And these treatments work better or worse depending on how they're sequenced. So we have to begin to think of exercise the same way as, how do we sequence exercise in relation to these other treatments? Because it may influence whether or not exercise is helpful as a cancer treatment. So for those of you not familiar with cancer treatments, this is what we'll call the modern cancer treatment landscape. So most patients now get multimodal treatments: surgery, chemo, radiation, immunotherapy, targeted therapy, other treatments as well. They get them sometimes combined. So sometimes we do chemo, radiation at the same time. They oftentimes get them sequentially, one after the other. So we do them over time in these patients. There's multiple lines of treatment when patients failed, first line, second line. In some of these metastatic cancer patients, we have 6 or 7 lines of treatment. So you can imagine how mutated and resistant some of these cancer cells become over time. And the disease can progress or recur multiple times. So cancer patients are probably the most heavily treated chronic disease group in any of the chronic diseases we work with. These patients go through a lot. And so this idea of how we sequence exercise within this very crowded and very busy treatment landscape, I think is going to turn out to be a very important issue. So if you look at those 2 variables and the 3 groupings, it sets up 9 what I'll call kind of generic clinical oncology scenarios. And so you can see you can have a primary tumor that's removed, and it can be, those micro-metastases can be treatment naive, actively treated, or previously treated. If the primary tumor is present, it can be treatment naive, it can be actively treated, and previously treated. So I'm going to kind of work through some of these scenarios, not all of them, but just to give you a sense of the type of research that's going on and some of the findings that are being produced in these kind of generic clinical oncology scenarios. So we'll start off with treatment-naive primary tumor. So the patient gets diagnosed with the primary tumor, but by the time we get in there with the exercise, they've not actually been treated yet. So this is very rare, right? Most cancer patients get into treatments very quickly. Oncologists don't like to leave any untreated tumors. So it's not a common clinical scenario. The clinical scenario where it does occur is called active surveillance. So sometimes we have patients diagnosed with very small tumors, low-grade tumors, they're not very aggressive. And there's an approach now where we say, we're not even going to jump in and treat those tumors. We're going to leave them for a while. But it's still fairly uncommon. It's particularly in the prostate cancer setting right now. It may grow in the future because there is a concern that some of these very tiny tumors are being overtreated. We're too aggressive in jumping in and treating these tumors. So you might see this active surveillance clinical setting become more common. And the role of exercise in this setting, I think, is potentially of great interest. So I'll start off with the preclinical models because this is where most of the preclinical research has been conducted in primary tumors or cancer cells that haven't been treated. So we're just looking at the straight effects of exercise on these cancers. And there's probably over 100 studies that have looked at this, and it's a very active area of research. And the way we do these studies is very similar to the drug study. So we can induce a small number of cancer cells, or we can implant a primary tumor in a rodent model. And then rather than random assign them to a drug or no drug, we randomly assign them to exercise or no exercise. And we can see what's the impact of exercise on these tumors in rodent models. And this is the general findings that have been produced in this literature across about 100 studies or so. And what you can see here, the general finding is that exercise slows the growth and spread of these cancer cells in these preclinical rodent models. The tumors grow more quickly. But there's a couple key points. One, about 2/3 of the studies show this pattern. Slower growth in the animals that exercise that don't exercise. But about 25% of the studies show no effects whatsoever. The lines are on top of each other, suggesting exercise really has no biological impact in those particular cancer cell lines. And unfortunately, there's about 9 or 10% of the studies that show the opposite effect. The rodents that exercise have accelerated tumor growth. So this is a cautionary note for us to think about, that exercise doesn't work for everything, and we have to be open to the possibility of some of these negative effects. The other finding you can see from this graph is, at best, exercise slows the growth of cancer. In none of these preclinical models do you see the cancer eliminated. In fact, you never see the cancer even regress, get smaller. And in fact, that red line is not even stable. We don't ever even see stable disease. So the tumors and the cancer cells always grow. And this tells you then, importantly, exercise is not going to be a cure for any cancer, not going to be a cure on its own. We have no preclinical evidence that these tumors are eliminated by exercise alone. But what this does tell you is there's some biological activity. There's something going on here that exercise seems to be having anti-cancer effects. Now, we have lots of potential mechanisms for this, and I'm not a mechanistic researcher myself, but it's just to make the point that there is strong biological plausibility for why exercise might slow the growth of these cancer cells. Things like androgen receptor co-activators, hormonal systems, immune system play a very important role in these cancers, anti-inflammatory effects, and so on. A lot of other growth factors. So we have good biology saying, yeah, the biology of exercise lines up well with some of the biology of these cancers. And there's even a more provocative and interesting mechanism that's been proposed, and it's this idea of hemodynamic shear stress. So when you exercise, of course, blood flow increases dramatically. And this is a preclinical model in a microfluidic system where they've got different sort of plastic tubing, and they can spin these circulating tumor cells through the system slowly or more quickly. And what they report here, and I'll just read this to you, it says, high shear stress achievable during intensive exercise killed more circulating tumor cells than low shear stress in human arteries at the resting state. And they go on to conclude we propose that intensive exercise may be a good strategy for generating high shear stress that can destroy circulating tumor cells and prevent cancer metastasis. So at rest, your circulating tumor cells are circulating through the cardiovascular system at a slower pace. So it's kind of like circulating tumor cells going down a water slide. You know, they kind of spin down there. Some of them die, lots of them die because it's a arduous journey. But when you exercise and dramatically increase the hemodynamic shear stress, this is like circulating tumor cells going down whitewater rapids. And it's a much more damaging journey for these circulating tumor cells. And this preclinical model shows that much higher rates of cell death for these circulating tumor cells under these high shear stress conditions. So this becomes another real interesting mechanism about how exercise might improve cancer outcomes. So let me share with you one of the clinical studies in this setting. So I mentioned that the active surveillance setting is really most common in prostate cancer. And so these guys get diagnosed with small, low-grade tumors and receive no treatments. So my former PhD student, Dongwoo Kang, had the idea, let's look at a high-intensity interval training program, 12 weeks of supervised exercise for these men on active surveillance, and look at biochemical progression. So these are treatment-naive primary tumors. And what he was able to show is indeed exercise influenced prostate-specific antigen levels. So this is a marker of how much prostate cancer might be in the prostate. So lower levels of PSA in the exercise group compared to the usual care group, lower PSA velocity, so how quickly the PSA is increasing, and a borderline significant impact on PSA doubling time. So suggesting that a marker of biochemical progression might be lower in the men who exercised. And even more importantly, he looked at an in vitro model of a prostate cancer cell line and subjected this prostate cancer cell line to the serum of the men who exercised versus those who didn't, and showed slower or less prostate cancer growth based on the serum in the men who exercised, suggesting there's mechanisms in there that are indeed fighting the prostate cancer. So this study got a fair bit of media attention, and there was a lot of interest from the urologists and the patients because there's nothing these guys can do other than wait around to see if the cancer progresses. So the option of doing something for yourself from a lifestyle perspective that could in fact influence your outcomes related to the disease is very attractive. And this was the headline, and I think it's a fairly accurate headline. Can working out slow prostate cancer progression? As I suggested, that's probably the best case scenario, at least in these untreated tumors. But slowing prostate cancer progression may be clinically important in this setting. If you can delay the need for radical treatments down the road, you're buying these men more time without the side effects of these treatments. So it could be clinically an important finding. Let's move now to the actively treated primary tumor. So this is much more common. As I said, we normally treat tumors right away. We don't like to leave them for very long, but typically we treat them with surgery. So the primary tumor is gone. In this case, we're not removing it surgically. And so we treat it with chemotherapy, radiation therapy, or other systemic therapies. And this is called the neo-adjuvant setting. So the goal here is to treat that primary tumor and get it to shrink or potentially even go away completely so that the surgery can be less radical. Or if it's gone away completely, we might not even have to do the surgery. So this is the idea behind the neo-adjuvant setting. And it fits with this clinical group of a actively treated primary tumor. So we've done a recent systematic review, and you can look up a number of studies here that have looked at this idea of whether there's synergy between exercise and a cancer treatment. But we've also done some preclinical studies. And we do it the same way as the previous preclinical studies, where a small number of cancer cells or a tumor is implanted, and we randomize them to exercise and no exercise, but then we also randomize to drug or no drug. So you end up with a nice 4-group design of rodents who get just the drug alone, just exercise alone, the combination, or neither. And you can really look at what's going on, what's the synergy between exercise and cancer treatment. And we've produced some very provocative findings in this area. This neoadjuvant setting is probably the most exciting treatment setting from an exercise perspective. So what you can see here, this is an example of these studies, and this is typical. So this is the common finding that's being produced. And here the drug is gemcitabine, so it's a common chemotherapy that's used. And so you can see the exercise alone has no impact. I mentioned about a quarter of the studies show that the blue versus green line. Yep, exercise didn't slow the tumor growth. The drug gemcitabine has a big impact, as we'd expect. So the tumor regresses and almost is eliminated completely, starts to regrow. But the combined drug and exercise group does even better. So even though exercise on its own has no impact, exercise helps the drug perform better in terms of treating the tumors. And why might that be? So we have really good biological mechanisms for this. And this is the vasculature of the tumor. Most primary tumors have poorly vascularized. So they're not getting blood to the tumor and they're not getting oxygen, which also means they're not getting drug into the tumor. Right? So it's poorly vascularized, it's leaky, it's chaotic blood vessels. And what they've shown in these studies is that when you exercise these animals, you improve the vasculature of these tumors. So you get a better vascularization of the tumors, more blood flow into the tumor, which also means more chemotherapy delivered to the tumor. And they actually studied it and showed, you can see the number of blood vessels within the tumor goes up in the exercised mouse compared to the control mouse, and the size of the lumen. So this is the opening of the blood vessels. So on the left, you can see there's kind of no dark circles there. On the right, you see those big dark circles? That's the blood vessels opening up. So now the chemotherapy drug can pour into those open lumen, open blood vessels, and more likely to kill those tumors. So we got very good mechanisms for why exercise might improve the effectiveness of chemotherapy. So this has stimulated some clinical interest in this area. So one of the first studies, I think it's the first one, is my former PhD student, Andrea Morielli, who's now at Alberta Health Services, had the idea of let's look at exercise during neoadjuvant treatment for rectal cancer and test this idea of whether or not it might improve treatments. And as I mentioned, it's not just improved chemotherapy delivery, it's improved blood perfusion and oxygenation. All right. And hypoxic tumors don't respond well to radiation therapy. You want oxygenated tumors. Those are the ones that are very sensitive to radiation therapy. So we've got mechanisms for both improved chemotherapy delivery, but also improved sensitivity to radiation therapy. And so she recruited 36 rectal cancer patients, very small study, and did a randomized trial looking at exercise during their treatment. So these patients get 5 to 6 weeks of combined chemoradiation therapy, and then they get a break before surgery because the treatment continues to work. So the tumors continue to shrink and they continue to benefit. And then they get surgery. And at that time of surgery, we can take a look and say, is the tumor gone? We call that a complete response, a pathologic complete response. Is the tumor shrunk? That's a partial response. The tumor's the same. We call it a stable response. And so you've got a nice 12-week window where you can do this exercise intervention. Much to our pleasant surprise, not only did we see a signal of a better response, it was statistically significant. So you can see here in the exercise group, about 55% of the patients had a complete response to the combined radiation therapy, meaning the tumor is completely gone at the time of surgery, compared to only about 15% of those who didn't exercise. So some early clinical data suggesting if you exercise while you're getting this combined chemoradiation therapy, you might get a better response to treatment. So this study also got a fair bit of media attention, and the headline here, as you can see, is very provocative. Patients with rectal cancer who exercise while receiving radiation therapy more likely to have tumors disappear. This will get the attention of cancer patients far more than a study showing fitness benefits or improvements in fatigue or other outcomes. So this is the critical outcome for many cancer patients. So this is a very exciting finding, despite being a fairly small study, but at least a proof in principle study. And then published just this past year is a study by Melinda Irwin out of Yale. And her team looked at, it was a combined diet and exercise, but diet had nothing to do with it, trust me, it's the exercise part. And they looked at exercise during chemotherapy, and they looked at both chemotherapy completion, but again, this pathologic response. And they looked at it, of course, only in the subgroup that got neoadjuvant chemotherapy. So this is the group where you get the treatment for the primary tumor. And you can see they report remarkably similar findings. Now, it's a subgroup analysis of 72 women who received neoadjuvant chemotherapy, and they note women randomly assigned to the intervention were more likely to have a PCR, pathologic complete response, than those randomly assigned to usual care, 53% versus 20, whatever that is, 28%. So another statistically significant, important finding. And this has prompted a group out of Sweden, I believe it is, to launch a large-scale phase 3 trial in this particular setting. So you can see here, this study is going to look at exercise during neoadjuvant chemotherapy for breast cancer as a means to increase the pathologic complete response rate. And their goal is to recruit and randomize 790 patients. So this is a large-scale phase 3 trial based on these very provocative preclinical and early clinical data. So we'll see what happens with this trial, but this could be one of those clinical settings where exercise might actually serve as a cancer treatment. So now actively treated micro-metastases. So as I mentioned here, a very common clinical scenario is the tumor gets surgically removed. So the only role for exercise there is treating the small number of disseminated tumor cells that we sometimes call micro-metastases. And we can look at it concurrently with other treatments, and we call this the adjuvant setting. So this was another one of the major findings from the START trial. So I talked earlier about some of the preliminary findings. The medical oncologist on this study, John Mackey, said, Kerry, why don't we follow these women up for the important outcomes down the road? In other words, recurrence of breast cancer, death from breast cancer, and overall survival. So that was his basic idea. So we went back to the electronic health records, and we followed these women up 8 years later. And we could see how many had recurrences, how many died from breast cancer, and how many died overall. And we compared the groups that exercised during chemotherapy, the aerobic resistance group, to the usual care group. And once again, very exciting findings in the direction that we would hope. The groups that exercised, their 8-year disease-free survival was 82.7%, compared to the usual care group, 75.6%. That's a 7% absolute difference in disease-free survival 8 years later if you exercised during chemotherapy versus not. If this were a chemotherapy drug, it would be approved and recommended to all these patients. That's a very meaningful clinical benefit. It's not statistically significant, so it's not a reliable finding, but it's in the direction that we would hope. And that got a lot of attention in the literature as well. And there's lots of mechanisms for it, but there's additional mechanisms related to this shear stress, this hemodynamic shear stress. So the same guys who did that previous study I talked about, where they spin the circulating tumor cells around faster and they're more likely to die, I've also found that if you're spinning these circulating tumor cells around faster, they're more likely to die from chemotherapy. So the ones that don't die from the circulation are more vulnerable to chemotherapy because of the damage they undergo during this sped up circulation. So now all of a sudden you begin to think, okay, if you're exercising while you're getting chemotherapy, are you making some of these circulating tumor cells more vulnerable to the chemotherapy? And that's what they suggest in this particular paper. So moving on to previously treated micrometastases. So here we're looking at what we call the maintenance setting. So the patients have been through their primary treatments, they've been through their adjuvant treatments, and now they're kind of done with treatments. And we're looking at the long-term outcomes kind of after they've completed their treatments. And this is the clinical scenario that most of the observational studies have actually looked at. So there's a lot of these systematic reviews. This is a recent one, but there's many, many of them summarizing all these observational studies where we look at physical activity after a diagnosis and whether or not it's linked to long-term outcomes such as recurrence, death from cancer, and so on. And so what these studies show consistently, as Don pointed out, is that higher rates of physical activity are associated with a lower risk of death from cancer and lower risk of recurrence in a bunch of different cancer groups. But what's not widely acknowledged is we've gone in and looked at these studies in detail, and almost all of them, the conclusion is that post-diagnosis physical activity is associated with these improved outcomes. But where post-diagnosis? Well, all of these assessments are 2 to 5 years after diagnosis. So none of them are during treatment. They're not during the neoadjuvant phase. They're not during adjuvant treatment. They're all well after these tumors and disease have been treated. So it's really making the case for exercise as a maintenance therapy after you're done all of your treatments. Somehow exercise can kill these remaining micro-metastases that the previous treatments have not been able to deal with. So this is really the clinical scenario of a large trial we've launched many, many years ago. And it's about come to fruition, called the Challenge Trial. So the Challenge Trial is a randomized controlled trial looking at the effects of a 3-year exercise intervention in colon cancer patients with high-risk stage 2 or stage 3 colon cancer who have completed chemotherapy. And so after they complete surgery and chemotherapy, they get nothing. And so we're randomizing these patients to exercise or usual care to look at exercise kind of as a maintenance therapy. Can it help clean up these remaining micrometastases? Because these patients have a very high risk of recurrence in the first 3 years after completing their chemotherapy. And this is a multinational trial, and we've just finished recruitment this past year, randomized about 850 patients. So it's going to be a very large phase 3 trial on this topic. And lots of help from people around the country, including Kristen Campbell's group here at Vancouver, but many patients on this study and have done a great job delivering the intervention. So excited to see the results. If these results are negative, you'll all be invited to my early retirement party. But if it's positive, it'll get a ton of media attention, and it could very well change clinical practice. So lastly, we'll look at actively treated metastatic disease. So these are patients who either at diagnosis or after a recurrence, the disease is now widely spread. What's the potential role of exercise there in kind of turning that cancer into a chronic disease where they can live, hopefully, for many years, even though they're unlikely to be cured? And so we refer to this as the metastatic setting. So we did one trial back in the day, and again, this kind of was ahead of its time in terms of reporting this outcome. And we called it the HELP trial, a healthy exercise for lymphoma patients. This was a randomized trial comparing aerobic exercise training to usual care in 122 lymphoma patients. 54 of them were on chemotherapy at the time of the intervention, and 68 were off treatment. The primary outcome we were interested in was quality of life, but we also collected secondary endpoints related to treatment outcomes for those 54 patients who were on chemotherapy. And we found the same signal we've seen in these other studies. So for the patients who exercised, lymphoma patients now, who exercised while they were getting chemotherapy, 46% of them had a complete response. So no evidence of disease after the chemotherapy. The chemotherapy worked very well, compared to 31% in the usual care group. Once again, suggesting that exercise while you're getting chemotherapy, even for widespread metastatic disease, seems to help the chemotherapy work better, presumably improving vasculature. Lymphoma patients will have cancer spread throughout with different lumps and bumps all over the body. So there'll be many of these tumors where exercise could potentially improve vasculature and improve chemotherapy delivery to those tumors. And then also this idea of any circulating tumor cells. And when you have widespread metastatic disease, you will be circulating tumor cells on a regular basis throughout the body as they break away and go elsewhere. So that previous study suggesting that those cancer cells may be more vulnerable to chemotherapy if there's a high shear stress. All right, so to summarize, most exercise oncology research is focused on supportive care outcomes and quality of life. These are very important outcomes to cancer patients. I don't mean to minimize them. These are extremely important outcomes, and these are the reason why exercise is being recommended to cancer patients and survivors for important benefits. We've seen some preclinical and observational studies that have come at it more from an exercise as a cancer treatment perspective, but we haven't seen very many of the clinical studies. And so I showed you today some what I'll call phase 1 or phase 2 clinical studies suggesting exercise may improve treatment efficacy in some settings. And in particular, it looks like this neoadjuvant setting might be very promising. Active surveillance setting might be promising, and potentially the maintenance setting as well, where most of the observational studies have been and where the challenge trial is looking at. So future research directions, well, of course, there's a lot. So it's not just these 9 generic clinical oncology settings I'm talking about. They all differ based on specific types of cancer, specific mutations that these cancers have, and all different types of treatment protocols. So you start doing the math in terms of all these possible treatment combinations for different types of cancers, and there's really thousands of possibilities where exercise may be able to serve as a cancer treatment. So we've got our work cut out for us over the next several decades. I'd like to end just by acknowledging many colleagues, many students, staff, and study participants who have contributed to this research, particularly Don McKenzie for his early collaboration and the influence he's had on my career. And it's been very much an honor to give the Don McKenzie lectureship. Thank you, Don. Thank you, everyone.
For those online, thanks for joining us. I think we had up to about 60 at one point. If you do have any questions, please put them into the chat. Jean-Sebastian Blouin will be collating those, and we'll bring those to fire Kerry's way. But first of all, thanks so much for an absolutely spectacular talk. Time for questions from the audience.
Thanks, Kerry. What a beautiful talk. I'm curious of your thoughts on ROS production during exercise, and also the counter-regulatory effect of ROS scavengers like SOD and catalase.
As I mentioned, Rob, I'm not a mechanistic researcher, so that's the stuff I haven't done too much on. But in particular, one study showed that it was the ROS generating mechanism that seemed to be responsible for the those chemotherapy drugs that cause that mechanism are what's vulnerable to exercise. So it certainly does seem like it plays a role. I mean, there's relationships such as patients who exercise before diagnosis are more likely to exercise afterwards. So they believe in the benefits of exercise and they will continue. In terms of the mechanistic stuff, you have to realize many of these tumors exist for a decade or longer before they're diagnosed. So what patients are doing before diagnosis, so to speak, is with a treatment-naive primary tumor. So that tumor probably, in some of these cancers, started a decade ago or 5 years ago, and it has to progress in size until we're able to detect it. So that means they're exposing it to that treatment-naive exercise. So it could be slowing the growth of that, which would delay the diagnosis, or it could also be reducing the likelihood of that tumor shedding any cancer cells. So hopefully, by the time you get diagnosed and get it surgically removed, maybe those patients who exercise before diagnosis are less likely to have disseminated tumor cells. So there could be some relationships with that pre-existing exercise.
Great question. Don?
Kerry, thank you. Could you comment on any possible use of intervening with nutritional manipulation, intermittent fasting, total fasting, and how that might play a role in the management of patients with cancer?
Yeah, well, nutrition, I have even less expertise, Don, than in mechanisms. But those ASCO guidelines that I talked about for the exercise recommendation, they actually reviewed exercise and diet. And they made no recommendations for any specific diet, other than to say, yes, for cancer patients who are malnourished, who have loss of appetite, head and neck cancers, radiation to the jaw, GI, nausea, vomiting, you have to make sure they get proper nutrition. But beyond that, to say that, the ketogenic diet or the Atkins diet or the Mediterranean diet improves treatment outcomes, they said there was no evidence, not just for the cancer outcomes, but for the quality of life and symptom management. On the other hand, as you know, Don, it's a very active area of research. They do all the same preclinical models, manipulating all the nutritional supplements, all the micronutrients and macronutrients and stuff as well. So I'm sure they're producing some interesting and exciting findings, but I haven't seen anything at the clinical level. And there's been a few large-scale phase 3 trials in nutrition. Right? You have the WINS trial, which was a low-fat diet in breast cancer. You have the WELL trial, which was increased fruit and vegetable consumption. And then there was a fantastic trial in active surveillance prostate cancer. So one of the areas I'm most excited about, They recruited 400 men on active surveillance for prostate cancer, randomized them to a high fruit and vegetable diet versus regular fruit and vegetable, followed them for multiple years and found no impact whatsoever on disease progression. The lines were on top of them. And beyond that, no impact whatsoever on quality of life. So that's some of the nutritional studies that have been looked at in terms of these clinical types of outcomes. Paul?
Dr. Courneya, that was an excellent talk. The question I have is, it seems like you guys have had really good positive outcomes and you have kind of clinical association backing for physical activity to be integrated into cancer care. To what degree has that happened? Has it been taken to scale across like academic cancer centers or more generally in kind of day-to-day cancer centers?
Yeah, it's quite variable. And so what you see is some of the top cancer centers have integrated these programs quite well. MD Anderson Cancer Center, Fox Chase Cancer Center, Dana-Farber Cancer Institute, Memorial Sloan in New York. These have well-funded programs, and they're part of what they call this integrative oncology program. So they've incorporated exercise into their programs. But it's oftentimes done through philanthropic dollars. It's not covered by the insurance companies, and it's oftentimes not paid by the patients themselves or through cancer centers. They have these philanthropic dollars that many people are willing to say, hey, I want to make sure patients have access to these complementary therapies and these integrated therapies. We're trying in Alberta. Margie McNeely has developed what we call the Alberta Cancer Exercise Program, the ACE program. And she's run that on research grants for 5, maybe 10 years now, but can't get the government to pick it up yet. So I think, different places have these programs implemented, but they're oftentimes because there's local researchers there who are actually doing it, and then they're offering some clinical programs on the side.
Maybe someone online, Jean-Sebastien?
Yeah, so thank you for the great presentation. I have a few questions from online. The first one is from Andre. Can you give us an example of what type of exercise, I lost it, are beneficial? So like, would it be as vigorous as like running, for example, or, yeah.
Yeah, so most of these studies have not attempted to compare different types or doses of exercise in looking at these outcomes. So a lot of the studies, like our active surveillance one and our Neo-adjuvant, are doing high intensity interval training. So it's kind of like we're starting with what we think is the optimal exercise program to try and maximize the differences between the groups to see if we can get an effect. So those studies have really looked at the high intensity interval training program. The START trial, where I showed the long-term survival outcomes, where we put the two exercise groups together, just for a power issue, we actually separated them. It was the same reduced risk, whether it was strength training during the chemotherapy or whether it was aerobic exercise. So it looked like both were having this beneficial effect. In terms of during chemotherapy, I mean, there is some suggestion that people think weight training may be optimal in terms of how you process these drugs and the side effects and how you might complete chemotherapy. And certainly Kristen's group has done a lot of research looking at lean muscle mass and sarcopenia and the implications, and it's fairly consistently linked to improved outcomes as well, which would suggest weight training programs may be beneficial. But we have no real kind of idea what particular prescription, not even in the preclinical animal models. We sort of just come up with a dose and compare it to no exercise.
Maybe if I could ask a question, are there any benefits around social exercise with regard to adherence? I know it ties to the breast in a boat and canoeing within group-based settings. So are there any benefits from exercising with others going through similar or comparable treatment, or does it not seem to have any additive effect relative to solitary exercise?
I'm not aware of too many studies that have directly compared, exercising alone to exercising group activity, but certainly we get those comments from our patients that the social aspects of the exercise are very important to them and very important to their motivation and adherence. So it's sort of, come for the health benefits and stay for the social benefits type of thing. So I think it is a very important factor. And when we report our quality of life outcomes or our depression or anxiety outcomes, we oftentimes get that criticism. Okay, these patients are exercising in a group or together, so how do you know it's the exercise versus the social interaction? So, to address that issue, what we've done and other groups have shown, we've shown that it's the improvements in fitness that drive these improvements in patient-reported functioning, patient-reported quality of life. So it looks like the bigger improvement you get in fitness, the more improvement you get in some of these psychological outcomes as well.
Yeah, great, thanks. Any others? Yeah.
We'll go online again. So one is related to the previous question. Is there any horizon on when some of these ideas might be implemented?
So I mentioned the one large-scale trial out of Sweden that will be viewed by the oncologists as a definitive study on that topic. So if that study is positive, I could see ASCO coming out with a recommendation for exercise during neoadjuvant breast cancer chemotherapy. There's a big difference here. You'll see the ASCO recommendation guidelines are saying you should exercise during any curative treatment to manage these side effects. And so they're recommending exercise for all types of patients, brain, lung, liver, breast, prostate, on all sorts of treatments, chemotherapy, radiation therapy, immunotherapy, and so on. For the treatment effects, you will not see that. You're not going to see improvements in the neoadjuvant setting, say all patients should exercise to get a treatment. It's going to be very specific to that scenario. So that trial is just being launched. It's going to, I'm sure, be a while yet. Our challenge trial, the CO21 trial, we should have results next year. So hopefully those results will be available. As far as I know, those are the only two what I would consider phase 3 definitive trials that are what we call practice-changing trials, where if those are positive, the oncologist will feel obligated to say, we need to put this into practice, and there'll be recommendations for those specific settings.
Maybe time for one more. Desi?
Thanks, Kerry. Speaking of different types of treatments, I saw that proton therapy treatment is coming to Edmonton with the Ben Stelter Foundation. Just curious if your team's going to be involved in any of this work, and do you suspect it'll have similar effects that you've seen as far as exercise being an additional benefit to that treatment?
Yeah, I'd have to look at it because you're right. Every type of treatment is a little bit different, but a lot of the radiation therapies work through this idea of this tumors being well oxygenated. So if that becomes kind of a generic effect that we're able to oxygenate these tumors through that, we'd suspect that type of therapy might work better. So a lot of the newer radiation therapies are really three-dimensional, conforming to the tumor, intensity modulated. So they are making a lot of progress on those. And whether or not exercise might be different, I think we'd have to look at it and see what's going on. What are the new mechanisms that these photon radiation therapy techniques might be addressing? And does exercise seem like it might play a role? And it's back to Don's point with immunotherapy as well. We don't have anything on the immunotherapy side, but again, it's a different treatment and a very promising potential interaction, Don, about the role of exercise in some of these immune parameters, which may help the immunotherapy work better as well. So every treatment is different and unique, and we probably do need research within those treatment scenarios.
Well, I'm sure Kerry will be happy to answer any questions afterwards if you'd like to hang around. But please join me in thanking Kerry for a fabulous talk.
Thank you.